Imagine this for a second. You're a surgeon. You walk into a room, a patient's life is hanging in the balance, and oh yeah, your entire career depends on the next few choices you make. Today, we're putting you right in the middle of that pressure cooker. This is a real surgeon's test, and you've got the front row seat.
So, you're standing in front of the examiners. They've just given you the case. A 66-year-old man in absolute agony. They're just watching you, waiting. The clock is ticking. So, what is your very first move? This isn't just a pop quiz. This is the culmination of years of training.
And get this isn't some made-up scenario from a textbook. We're walking through an actual case from a real consultant surgeon's exam, straight from the Saudi Commission for Health Specialties. We're going to break down, step by step, exactly how a top-tier candidate is expected to handle this kind of pressure.
Okay, so here's how we're going to do this. We're going to follow a candidate through what's called a viva, an oral exam, as they try to solve this case. I'll be playing both parts, the tough, pointed examiner and the calm, cool, and collected candidate.
So let's meet our patient, Nazar. He's 66, and his complaint is a classic surgical emergency. We're talking sudden, really severe abdominal pain. And here's the kicker. He can't pass stool or even gas. Now, that condition is called obstipation, and it's basically a giant flashing red light for a complete blockage somewhere. The clock has officially started.
All right, with that terrifying initial complaint on the table, it's time to start digging. And the first step, well, it isn't a fancy scan or a lab test. It's just talking. It's about building that clinical picture, one piece at a time.
How would you approach this patient? The question is intentionally broad. The examiner wants to see if the candidate has a plan, a system.
And the candidate's response is immediate and structured. No guessing here. They're going to dive deeper into the pain. Check for other signs of a blockage, like a swollen belly or vomiting. And then, here's the crucial one. They ask if this has ever happened before. See, that last question is a massive clue. If this is a recurring problem, you start thinking about a mechanical issue, something that's physically wrong, not just a one-off infection. And boom, the history comes back, and it confirms the worst fears. Nasir is vomiting, he's totally blocked up, and yup, he says this has happened before. That one little question from the candidate has already started to narrow down the possibilities in a huge way. So, what's next?
What will you do next? The examiner keeps the pressure on. History's done. What's the logical next move?
The candidate moves right onto the physical exam. And notice how systematic this is. You start with vital signs, is the patient in shock? Then you go to the abdomen, looking for swelling, checking for hernias that could be causing the trouble, and then you're looking for those really dangerous signs of something called peritonitis. This kind of methodical approach, that's a huge point scorer in these exams.
And the findings from the exam are not good. The patient has tachycardia, which means his heart is beating over 100 times a minute. His body is under a ton of stress. His belly is incredibly swollen and tympanic, which means it's so full of air it literally sounds like a drum. But the worst finding? Rebound tenderness. That's when the pain is actually worse when you let go. It's a textbook sign of peritonitis. This has just been upgraded to a full-blown surgical emergency.
Okay, so we have the history and some very alarming exam findings. Now, inside the candidate's head, a list of all the possible culprits has to be forming. This is what we call the differential diagnosis. It's one of the most important parts of being a doctor.
What is your differential diagnosis? Now, the examiner isn't looking for a lucky guess here. They want to see the candidate's thought process. They want to know you've considered all the things that could cause a massive bowel obstruction in a man this age.
And here is the candidate's list. It's perfect. It's broad. Colonic volvulus, that's a twisted colon, is probably at the top, especially since this has happened before. But you also have to consider things like cancer, a severe blockage from stool, or even inflammatory causes. The point is to show the examiner you're casting a wide net before you start honing in on the real problem.
All right, we have our list of suspects. Now it's time to find the real culprit. But even more important than that, it's time to stabilize this very sick patient and come up with a plan.
Now, this is so important. Before you rush to find the final answer, you treat the patient in front of you. And the candidate knows this. The first steps are all about stabilization. Get him admitted, NPO, nothing by mouth to let the gut rest, put a tube down his nose into his stomach to relieve the pressure and stop the vomiting, start IV fluids because he's definitely dehydrated. All this has to happen to get the patient strong enough for whatever comes next. This is life-saving stuff.
And now, the moment that cracks the case wide open. A simple X-ray is done, and the report comes back with a description so classic it's famous. a massively swollen sigmoid colon that looks just like a bent inner tube or a coffee bean. That, right there, is the smoking gun.
With this finding, what is your diagnosis? The examiner asks. The time for a long list of possibilities is over. With evidence this clear, there's only one answer they want to hear.
Colonic volvulus. The candidate nails it. It's a twist in the colon, basically. The sigmoid part of the colon has twisted on itself, cutting off the blood supply and creating this huge trapped pocket of air. It's a beautiful example of how that structured approach, history, exam, and then a targeted test, leads you straight to the right answer.
And the plan to fix it is just as clear. It's a two-step process. First, you have to solve the emergency right now. That means using a scup to guide a tube up there to untwist the colon. That provides immediate relief. But the reason it twisted in the first place is still there. So once the patient is recovered, you go in for a scheduled surgery to remove that problematic section of the colon so this never, ever happens again.
So the patient's immediate danger is over. They've been treated. But for our candidate, the exam isn't quite finished. Now they have to show they're thinking ahead. They have to prove they can manage the patient after the surgery and anticipate what could go wrong.
What complications will you monitor for post-operatively? The examiner asks. A great surgeon knows the job isn't done when the last stitch is tied, and the candidate needs to list the big ones: bleeding, infection, and the most feared one of all, an anastomotic leak. That's when the two reconnected ends of the bowel start to leak. It's a disaster, and you have to be watching for it constantly.
And really, that brings us to the biggest takeaway from all of this. That methodical, step-by-step process, it's not just a script you memorize to pass a test. It's a life-saving algorithm. It's a framework that brings order to chaos and ensures that when someone's life is on the line, nothing gets missed.
And there you have it. From a vague, scary complaint to a life-saving procedure, all navigated by having a clear, structured plan. That is the heart of what makes a great surgeon. So, what other medical mysteries or high-pressure situations do you want us to tackle next? Let us know.